guide the pruning process rather than to leave it to chance. So the more we use it, and because if you look at the image, right from the time the baby is a newborn to the time we are adults, look at the speed at which the neural connections are being made. So that is, so again, early intervention is extremely important because this is a phase where we need to kind of give as much supportive environment as we can for our children. Now, this is another very nice visual that we have for the human brain development timeline. So here, Dr. Ross Thompson and Charles Nelson, they outlined how the human brain development is influenced, it develops and is influenced by the genetic as well as the environmental conditions, right from the prenatal to the adulthood and later on in life. And it's like, it tells us as to each and every experience that we have every day is so meaningful in adding to what we become eventually. So again, as a part of the brain development and human development theory, it's something which we need to keep in mind, especially when we are talking about early intervention. Now, when we are talking about the sensory development, we cannot not talk about the synaptic theory of development, which was developed by Dr. Heidi Alls. She was a clinical psychologist in Boston, and based on her synaptic theory, the NIDCAP, which is the Newborn Individualized Developmental Care and Assessment Program, was formulated, which focuses on giving a supportive environment for the babies before they are born, for the preterm babies, so before they are term. So this is where we are trying to focus on creating a neuroprotective environment where we are supporting the autonomic system, the motor system, the state, the attention, and the emotion regulation system. So this is the foundation time before we are really talking about the other domains of our neurodevelopmental or our cognitive assessment. So, this theory helps us see that development is an interaction between all the different domains, and it's not isolated as one system, and it happens through the ongoing exchange between the child and the environment. So, this matters clinically because difficulties in one area can often affect the others. So, for example, poor self-regulation may interfere with attention, feeding, language, and social engagement. So intervention should be supported, so should support the whole developmental system rather than just getting stuck on one thing. So again, an important factor that we need to remember, especially when we are talking about early neurodevelopmental intervention or assessment. Now, coming to the current policies and framework, India's neurodevelopmental assessment and intervention framework is anchored in the Right of Persons with Disability Act and the Mental Health Care Act. These policies legally mandate early early identification, rehabilitation, and inclusion of uh, the cerebral palsy and autism spectrum disorder, intellectual disability, and so forth. So the policy frameworks are important, and because they basically, and if you see, after 2017, there are different other policies which have come up to support the services, and it is important because having a framework and having a system which is more organized, it helps us to deliver the kind of work that we really want to do. So in practice, these policies, they help whether the child is screened or not, whether the child is referred properly, and whether the child is being followed up properly or not. And so if we talk about the overall issue, the main important thing comes as the implementation of it. So it's easy to make a policy, but it's very, very difficult to kind of implement it. Because even if the policies exist, families may still face the delays unless system is designed to work across different levels of care. And this is why a strong reference system, a referral pathway, standardized screening, and clear responsibilities across the team with the multidisciplinary professionals is essential. And so, keeping those policies in mind, because now we are talking about the age range of the 0 to 6 years, uh, which is a remarkable time for the brain development. The government of India, it started as a trial with a single window early intervention center with seven centers in the National Institute and seven in the cross composite regional centers. And later on, then they increased it to 14, and then now we have 22 cross-disability early intervention centers for children, which are operational across various national institutes. However, and when we started again, and like some of the research that were done, the common factor that came in was again that the policy is fine, but implementation becomes difficult. There are a whole lot of gaps. Convincing people working as a multidisciplinary team, that becomes difficult. And different early intervention centers run in a different manner depending on their own capacity. So it's very, very important for us to actually look at where we are, what we really want to do, how we need to focus on these things, and what is the best way in which I can give the best care based on my resources. So, being thinking similarly on those lines, we from the armed forces we had set up the early intervention centers called Chetna. Like and Army has one, Army has the early intervention center, Air Force has early intervention centers, and this is how it had started. The story started with us again trying to do some work initially independently and then actually having a thought as to why can't we have a center where everybody is under one roof? Why do we have to, or why do the parents have to keep running around here and there and try to get the best care and support for their babies? So based on this, we had done a study in 2019, which came up, which helped us give the foundation basis of how we can make this work out. And in 2021, we had the first Chetna Early Intervention Center with the Indian Navy in Mumbai. And later on, subsequent different centers were opened up, which, have been very, very helpful for the families. The peculiar thing about our early intervention centers are that we are a moving population. So every 2 years or 3 years, we keep moving. So it was very difficult for the families to actually continue the care. So these centers are made in such a way that we are able to, or at least we attempt to kind of uh, do the transition from one center to other in such a way that there is not much loss of time or effort. However, so while we were doing it, we had to go through like a lot of other processes. We too struggled with the implementation of who goes where, who which discipline works first, who comes second, how to kind of create the process. And based on that, that is what the story was behind us writing that book. Um, Now, coming back to the topic that we were talking on, so that was like I had just zoomed out a bit to talk about our story, just to kind of let you know where I come from. Um, the important factor is that irrespective of whether it was a government setup or whether it was our setup, and I'm quite sure that all of you who are working in this field would have also gone through the same experience that policies are fine, but how do we kind of make it work? And the same thing came across. Was spoken by the consensus statement by the Indian Academy of Pediatrics, where they did outline that screening for the developmental delays needs to be done. We need to kind of use the multidisciplinary team. And they talked about the fact that although early neurodevelopmental intervention is widely endorsed, its impact depends on how effectively the services are organized, coordinated, and delivered in an everyday practice. So it requires a multidisciplinary model that integrates developmental surveillance, psychology-led family support discipline, focusing on specific therapy, and linking it with the community for the follow-up to make it a coherent same roof and to create a system which will be helpful and meaningful is something that we are learning every day in our practice. And that is what my aim is today, to talk a little about what we learn from our experience and how probably that can be helpful for everybody who's listening here. So when we talk about the Early Intervention Center, we have a multidisciplinary team that brings different perspectives of, like, their own profession. So the most important stakeholder is the parent. We have the medical team, the pediatrician, the psychologist. Then we have our the entire therapy team, the psychologist, the occupational therapist, speech, physiotherapy, psychiatry. Now, because we are talking about children from 0 to 6 and above, initially the patients come to the pediatric setup, and that's the reason the pediatricians need to be very much aware of doing the screening in time and following it up, because most of the time and because that is the time where we are talking about the brain development, so we need to catch that time. As the child grows older, from 3 years onwards, then it becomes more of a collaborative between the pediatrician and the psychiatry team, and that's how it works. So, from the it's if you look at it from the medical side, the medical team is used to working together, because when they have to kind of do the cross references and referrals, they do that. However, it's a very new area where now the medical team has to work with the allied health team, and the allied health team has to work with the medical team. So that is a new zone which we really need to work on so that we can collaborate better. Now, when we talk about team dynamics, uh, the team workflow model ensures that the assessment and the intervention are coordinated rather than fragmented. And it also helps professionals to actually understand when their input is needed, when can I step back, when do I need to kind of contribute in the overall plan. And it's especially important with the multiple concerns that are present, because neurodevelopmental assessments and early intervention, the whole thing is a dynamic process. The brain is still developing. There are so many other things that are involved in it. So we need to be very, very mindful of where I am placed as a professional. So instead of a separate, disconnected recommendation, the team should develop a shared understanding and a shared plan. And this improves the clarity for the families and makes treatment more efficient. So in India at the moment, if we look at it, we are mostly working in the multidisciplinary or the interdisciplinary framework. Some of the private practitioners would be working as the monodisciplinary, where you would be doing the assessment and then sending it to somebody. But uh, transdisciplinary is like a utopian space where some of the institutes would be working, but practically all are not. Transdisciplinary is a system where everybody comes together, the parents are also working together, and making a plan together, and then creating a framework based on the outcomes which they have seen. So the problem is seen, like, so what is happening is that we are taking in transdisciplinary, you are taking and borrowing the strength from each profession, creating a system which would be more helpful to address the problem and then go for it. So that is the ideal situation. However, based on our capacity, again, we need to see as to what is the best that would work for me. Now, irrespective of what kind of a team model that we work on, this is the overall view that we are assuming that we should be able to achieve when we are talking about the assessment as well as intervention. So if you look at the left-hand side of this image, the first thing, because the clients are mostly going to come, because they are small, they are mostly going to come to the pediatric side, we need to first do the assessment and the screening for the clinical functioning, the genetic, metabolic, neurological, or anything of that sort, so that we are able to actually put aside what, or have a better understanding as to what is the medical reason why the child would be probably behaving in a particular manner. After that, then we kind of get the input from the different professionals, which is the psychologist, the occupational, the physio, the speech. We do the assessment, we get to the understanding of what is happening, we involve the parent, and then we also look into the functional ability of the child, because when the child is small, we are then looking at the domains of the motor activity and the activities of daily living, the language development, how that works out, because that is eventually then going to go into the scholastic ability for the child. So when we are talking about the overall assessment and the intervention for these young children, we are looking at identifying the medical causes, seeing what is the baseline developmental level for the individual, seeing where the functional ability of the child is, involving all the stakeholders, the parents, the families, helping develop or improve the skill level, as well as reduce the behavioral problems, and then kind of help in the translation from the centers to the real time activity, the real experience in life, which is the school preparedness, and then to kind of see how it will be when the child is going either to an inclusive school or to a regular school, and how do we work on that. So that is what the entire contribution of the entire multidisciplinary team would be. Again, depending on whether it's a hospital-based early intervention center or a community-based early intervention center, you will have the professionals coming in and out from that perspective. So, in an early intervention center, excuse me. So, an early intervention center which is hospital-based, I'm so sorry. Um, you will have the core team as the medical professions and the therapist. But if you are in the community based, you will always have the special education. I'll just take a off this thing. Sorry for that. That's my excitement speaking. I forgot that I was not well. So this is the overall view of what we are really looking at. Yeah. And as I talked about earlier, the pathway to the early intervention center would be 0 to 6. So it can be from the early intervention center. It could be in the pediatric and the psychiatric departments, or it could be the community centers. Here I've highlighted more from the pediatric center, so it can be the NICU graduates, which are the high risk infant follow up, the pediatric intensive care follow up, where the children are either unwell or have a post surgery, because that also makes a lot of difference. So we need early intervention in that area too. The pediatric OPD is one space where most of the children will be seen. They come for the developmental clinic or for the parental concern. So what we are looking at is that if we are able to um, give attention or focus on the screening and the assessment and the intervention early, we are actually supporting habilitation rather than going into the zone of rehabilitation. So before it becomes too late, we are just trying to use the neuroplasticity concept so that the brain is able to kind of adjust and accommodate accordingly. Now, the developing brain is best understood through its changing structure and the function over time. So, different domains mature at different rates, as we saw in the synaptic theory, and skills are built on earlier capacities. And that is why a child's difficulty should always be understood developmentally, and we should not really get stuck on one aspect. Also, like because and that's the reason why we are talking about developmental assessment, because the brain is still growing. So a problem in language, social interaction, or a motor development may reflect a broader developmental trajectory rather than a single isolated issue. And that perspective helps us to make a better decision in the assessment and the intervention. And as you can see, the entire assessment and process actually goes based on the central nervous system development, the way it matures. So initially, when the babies are small or preterm, we are basically doing the neurobehavioral assessments or observation. We are not really doing any kind of a assessment. We are doing an intervention based on what we are seeing. So it will be dependent on the way the baby is breathing, the autonomic system, the colors, the digestive process. This is for the younger babies, the motor stability, whether how their tone is. Then we also look at the sleep and states, how they are sleeping, whether they are able to regulate their sleep properly or not, and whether the small babies are able to give eye contact, and make face-to-face contact as newborn infants, and they are able to kind of regulate their own emotion. Where if the baby is crying, can the baby kind of is able to kind of quieten up himself or herself. So that is what we will be doing in the neurobehavioral assessment. And then as the central nervous system matures, then we go into the neurodevelopmental assessment, and then later on, then we go into the cognitive assessments. And that's the reason, if you remember that the brain timeline image that I had shown you, you would see that the cognitive development is usually happening around 4.5, 5. So that's the time where it is expected to mature. And that's the reason most of our cognitive assessments will happen from that age onwards. Yeah. So now coming to a neurodevelopmental assessment, it tracks the functional development of the central nervous system, and it looks across the child's domain, a specific profile. So it helps us to understand not only whether the child is delayed, but also gives us a better understanding of how the development is unfolding. So a typical developmental trajectory would provide us the baseline against what we are what our concerns are. So when a child deviates from the expected pattern, the next step is to ask why. And why is this happening? How severe it is? And what are the support that is needed? And this makes the assessment a planning tool also, and not just get fixated to a diagnostic tool. What we really need to understand is that yes, neurodevelopmental assessment is important. We need to get a baseline understanding as to where the child is functioning. But at the same time, we also need to remember that we shouldn't get stuck to the score or to the disability percentage. We need to do the assessment with the idea that I am getting an idea as to where the child is and what is needed for the child to do. So, because that would then help us plan for the therapy also. Now, we can't talk about neurodevelopmental disorders without talking about the DSM-5 and the ICD-10. So, these are the classifications that is used for the diagnosis. Mostly the differences in the English language, it actually makes it's the same thing. But the key point here to note is that because of the classification, it should not narrow down our perspective. So many children have mixed profiles. They have evolving presentations and coexisting conditions. So diagnosis should support care and not replace our own clinical understanding. Yeah, so we need to be very, very careful there not to get stuck with labels, but to actually be able to see the functional aspect of the child too, and then work with them accordingly. Now, obviously, red flags are the signs that this is how we will identify the neurodevelopmental disorders. So it's important to kind of identify the red flags, and it's also important not to wait for too late. So when you're seeing the red flags, it is important that we enter the child into the developmental pathway as soon as possible, so that the evaluation and support can begin as early, so that we are able to actually support the child better. Now, when we come to the screening and assessment, this I would say is one of the most important slides of today's thing. So this is how we work together in a multidisciplinary team. So as I said earlier, so medical evaluation would be the first one. Um, the sequence is essential because first comes the medical and the developmental screening, where the medical management is done and where basic parental counseling is done. After that, the individual, therapist do the assessment. So with the physiotherapist, we will do the assessment and talk to the parents about it. The psychologist would do the developmental assessment, And another thing that I felt in my experience that adds to the value is that while the other professionals are doing their assessment, like while the occupational therapist, speech therapist, and the physiotherapist are doing their assessment, and after the clinical psychologist or the rehabilitation psychologist has done the developmental assessment, they need to also have a conversation with the parents so that they are able to actually induct them or get a better understanding of the lifestyle that the child is having, because we need to get the biopsychosocial feedback and background, and also train the parents to introduce them to the therapeutic experience that they're going to have. So introduction about the visual timetables and the behavioral management, that is an important conversation that needs to be done at this point also, while the other assessments are happening. And once the assessments are done, then all the professionals come together to create an individualized early intervention plan. Each professional contributes, like, a bit of part of their report and uses the information to finalize a remedial thing. So the remedial plan that is made, it is always going to be a collaborative effort rather than I feel that this is to be done and I will do that. Because in that, what happens is it's the same activity which is being repeated over and over again, and the parents are just running from one specialist to the other, doing the same thing, not really understanding who is more important or what. Ideal situation would be that if everybody comes together with their plan, creates their own domain, creates their own identified plans, then you are able to actually save time and use one activity which is going to probably stimulate many other activities or domains. So this is something which requires a little work and collaborative planning. So once learned, it is a good system to work on. So anyway, coming to the screening and the medical examination, it should begin early and continue at regular intervals, especially in the high risk children. So this slide shows about the neonatal follow-up, how that would be the timeline of it, as well as the screening for the neurodevelopmental disabilities. And it's important to understand that uh, we should not get stuck onto one tool itself, but we need to kind of look at the entire surveillance. We need to kind of use our clinical judgment and skills also at the same time, and follow up. And because follow up is one of the very important things, uh, because because the child is still developing, the speed at which the catch up would happen would vary. So it is important to keep an eye and do the regular follow ups in the well take up babies, or the when the baby the when the child comes for the immunizations. Now, planning the neurodevelopmental assessment. So we know that it's a comprehensive standardized evaluation which is conducted by the qualified professionals to diagnose the problem. Um, so to start with, we need to start with a referral question as to what has the child come with. Think developmentally and not diagnostically, because a lot of time we make this mistake that this person is looking like this. So we already have a judgment. So rather than that, look at what is really happening developmentally with the child rather than going for a tagline. Gather information from multiple sources. Look for a pattern, because behavior will always have a pattern. Make the assessment child friendly, because if you are intimidating or if it's a noisy place full of distraction, it's not really going to be, the child is not really going to engage with you. So your own body language, your tone, your voice, the way you interact with the child, that makes the world of a difference in the assessment. Identify the strengths along with the deficits, because when we are doing the assessment, we are not really looking for the problems only. We're also looking at what are the things that the child is good at, because we will be using that for the therapeutic interventions later on. And of course, we have to prepare the family in the entire process. So just for example, so if a child has come with a speech delay, the key thoughts that should be there in the head would be, what is, like, what am I really looking for? So let me look at the differences in the social communication. So I know I'm thinking I'm trying to rule out autism here, but I'm looking at other factors also. So because speech delay, we need to kind of clear off the medical reasons behind it. So we will first do the work upon that. We will then also look at how the child is interacting with others. We will then obviously assess the developmental baseline. We'll do the joint play and the language and the pragmatics. We'll try to see if there are any other coexisting conditions. We'll explore the family dynamics because we are also trying to rule out any kind of a trauma experience or a lifestyle schedule or a dysfunctional family. So the background story always matters a lot. And then after we get all the information, it is important for us to actually think about the child, the behavior, and the context of it, because that is important. Because once we are able to actually formulate our entire assessment based on, like, our entire planning of for the child based on these thoughts as to why this behavior is actually happening, it would give us a much better perspective. Now, I have just outlined this slide as so these are the tools which have been recommended by the government uh, related to the assessment for the neurodevelopment. Like some of them I'm not very happy with, like especially when we are talking about Vineland social maturity scale. It doesn't really catch much when we are talking about the developmental delays. So, although the developmental assessment tools like the DST, the DASI or the Baileys are not mentioned. Sometimes what you can do is for extra information, you can do the developmental screening because they are domain specific and they give you a better understanding as to what is happening. Because uh, had they chosen Vineland adaptive behavior scale, that would have been a little more meaningful than the VSMS, because VSMS doesn't really catch the behavior patterns that we are looking at the younger children. So that is a little gap that we have. You can make do with it by using the developmental assessments tools like the DASI and the Bailey. Another important factor in the assessment is the way we do it. It's not like just a checklist that, like, oh, is the child doing this or not? It is very, very important to use your clinical judgment. It's extremely important to see what is happening, the behavior observation, the interaction, and, then go by that. Especially for the autism diagnosis, because when we are doing the autism diagnosis, it's a very, very dynamic kind of an interaction that is happening, because you have to be very, very conscious of what exactly are you looking for. So even though the conditions are there and the domains have been written clearly as to whether the child is doing this or not, you have to still observe the interaction. You have to still observe the response of the child. So while we are doing the assessment per se, it's very, very important to understand as to how we are doing it rather than why we are doing it alone. So once we have done the neurodevelopmental assessment, so I'm assuming that this is what the domains that we will have. So we have the gross motor, fine motor, activity of daily living, cognition, reception, receptive language, expressive language, social communication, emotion, and the sensory development. We then create a developmental profile, because when we have a profile, it gives us a very nice visual as to where is this child actually needing the attention. Because when we do that, it helps us again then plan. And because when we are talking about neurodevelopmental assessment, we are not only talking about the developmental assessment, the tool. We are also talking about getting information, from the parent. We are talking about the direct observation that we have had and experienced, our clinical judgment, the general medical physical examination that has happened before that, the systemic examination that the child would have gone through just to rule out any of the medical conditions there, the developmental assessment definitely, and the case specific assessment, what did the child come to you for? So even if a child has come to you for autism, you will not just do the autism assessment, you will also do the developmental assessment, because you still need to know the baseline level of the child's development. Yeah. And another thing which is really helpful is to do the functional assessment also. because the functional assessment, as you can see here, gives us the idea of what the skill level is. Because and this again becomes a very, very important point where it helps you shift. It's kind of a bridge between the assessment and the intervention. Because when you've done the entire neurodevelopmental profiling, you know where the child is weak, that cognition is low, the speech is low, the expressive is low, and the receptive is low, and everything. But now what? The question comes in. So when you do the functional assessment, it actually gives you much more activity-based um, ideas as to where the child is able to do it or not. And then I find the NIPID basic MR very helpful because the grading, the scoring of these tools is graded. So it is 0 for completely dependent, two, it'll kind of keep increasing by, like, partially dependent or needs queuing or partially independent or completely independent. So when you are doing your intervention and when you're planning your entire activities or the therapeutic activities, it gives you an idea as to what level the child needs to go. So here we can see that the part A is a skill level thing. So our main goal is that by the end of the year or after 6 months, we are seeing some kind of an increase in the scores so that the graph goes up. And in the other form, which is the form B, which is the behavior problems, the expectation would be that with frequent interventions, the behavior problem will come down. So the scores in the behavior will come down. So it's a very nice and easy visual that we can then create. So this is predominantly the domain of the special educators. However, if you are working in an early intervention center, it's very helpful to have this because it gives you, it makes making your intervention plans much easier. And when we are doing the report writing, most of the psychologists, we are aware of this. We do it on the 5P formulation. We think about what is the presenting problem, predisposing factor, precipitating factors, perpetuating factors, and the protective factors, because these are the these are the information which helps us formulate why a behavior is particularly happening and what is the kind of support system I need to provide so that we are able to kind of help the child and the family. Yeah, now we come to the setting of the goals, the individualized early intervention plan. So this is a space where we now gather the inputs from each and every professional, see what everybody thinks, and then we make a common goal. And this common goal is important because it helps us stay focused on the target. It helps us set achievable goals. It emphasizes on the objectivity. It gives clarity of what is needed. So, with terms of the long-term goal and the short-term goals, and it helps us a clear scope for, regular reviews, and it also kind of generates a accountability and responsibility. So especially when we are going in for therapy, when we are doing the same thing over and over again, it's very difficult to then even think, like, is this child even making any difference or not? Because small differences will not really come up so openly. But when you have broken it down into smaller tasks and plans, it kind of gives you a little visual as to what is really happening, and it gives clarity even to the parents. So when the parents have a clarity, then they are a little more involved in this interaction. So it's a very busy slide, but I had tried to kind of help create a visual as to how to create the individualized early intervention plan, which needs to be developed based on the baseline of the child's ability level, and then we increase it to the family priorities and, how to create it with the short-term goal. So, so the first step is identifying the domains which we have already acquired from the neurodevelopmental assessment that we have done. Okay, then once we have identified then the second step is to kind of assess baseline skill. So what is it that we really need to work on? So here, for example, I've given that my identifying domains is behavior problems, difficulty in transitioning, throwing spoon. So basically, behavior issues are there. I'm looking at more of a psychological aspect of it. Then the access to baseline skill would be develop effective coping things. So that's my aim. That to help the child, I need to improve the task persistence and also to talk to the parents about it, how they can develop it. Then the phase three would be breaking down long-term goals into short-term goals. So here we are making manageable milestones, which can be done within 1 to 3 months, and we can then break it down into smaller tasks. So the long-term goal would be we will use appropriate coping when frustrated during mean times, and the short-term goal would be that we would be the name of the person, I'm assuming, will be able to identify his emotions during mealtime. So this is how I will then break down the task into smaller tasks. Then identify resources and support required. So many times, if suppose it is a task which requires the child to sit at a table, so then, and if the child is not able to, then we will be talking about a suitable chair or like, some kind of a support system there or a cushion. If suppose it is a child who has a developmental delay where they are not able to hold certain objects, so then you will provide the spoons or the objects in such a way that they can hold. So especially you would see it with a child who's not able to have a pencil grasp. So you will actually, instead of having the thin crayons or a pencil, you will give the thicker one. So this is a space where you will be creating the resources that is needed to complete the task. So here the task would be the parent support is needed, environmental support, you will get everything together, and then you will kind of prepare for the intervention. Then the fifth step is breaking down the short-term goals into tasks. So create clear action plan for the activity. So the action plan would be we will play emotion identifying games, happy face, sad face, angry face. So you are now what you're doing is you're breaking down a bigger goal into smaller goals, making it more doable and achievable for the person. Yeah, and then you will break it down into the task analysis. So it will be task analysis is a clear, concise, small step needed to develop complex skills and behavior. So break the previous step into smaller series. So if suppose I have to say that like the child will play happy face or a sad face, so we need the support system. Obviously there needs to be those images, and then you have to break it down as to how you would do it. So are you going to do it with an object? Are you going to do it as an interaction? How are you going to do it? So that is a step that you will break that down into. So that is called the task analysis. And then you kind of keep doing that. So you monitor and evaluate progress. So when you have broken it down into the task analysis, you are then trying it out as like, on a discrete trial sheet, which will help you see whether, and if you have given it a graded scoring, then you will be able to see whether the child is making improvement or not, or whether the goal is being achieved or not. And then the last stage would be to reflect and adapt and review as to whether what is happening is the task too simple or is the task too complex? Is this a task which the child is not interested in at all? So this is the thought process which actually goes into creating an individualized early intervention plan. So what you need to do is as a therapist, so when you are collaborating with the entire professionals, then like all of you will get together. You will see what domain is needed first, what is important, and then based on that, you will make these tasks and then write the individualized early intervention plan. So the writing principle of this will be strength based, which in which you will write that so and so enjoys social games known with known adults. You will use a parent friendly language and you would avoid technical language. So rather than saying the child requires oromotor skill intervention, you will write the child requires intervention with the lip, tongue, and the jaw movement. Suppose, like, and then to make it easier and achievable, the task then will be a measurable goal where, like, you can say that, like, the so and so will say 2, 3 word phrases to request 4 out of 5 times. And if sometimes you feel that even 2, 3 words is too much, then you make it lesser depending on where the child is because you have done the assessment, you know what the baseline level is, so your activities and your action plans will be based on where the child is. So this is how you create the IEIP. The creating the IEIP can be done with the parents, without the parents, but it is done as a team. Ideally, it will, if you are able to, what you can do in the Indian setup is you create your own IEIP along with your team, work it out, and then you can engage the parents in it, get them more involved and get their input, because then they'll be able to actually tell you much better as to what their child likes and what they don't like, and then you can move on with the intervention plan. Yeah. So then we come to the reviewing goals. It's essential because this is the time where you actually are able to see what your priorities are, whether the progress is happening or not. You compare the work which is done at your clinic, your home, and school. Um, it also keeps the functional, the goals very functional, because you are obviously making it more meaningful. It is going to be child-centered. You'll adjust the goals if progress is slow or need to be changed, and you can review the plan the next step. So when we are reviewing, what's happening is that we are still keeping it in control. We are not just mechanically doing something, we are actually identifying as to what is helpful and what is not helpful. And if you look at it, it also creates a pattern for the family and the child, which is much more doable. So that expectation that this activity is to be done will be there. So it kind of creates a sense of predictability, which will help with the maintenance of the goals in the future. And of course, you have to take the feedback from the parent also at the same time. Um, for you, it is important to reflect whether the child has made measurable progress or not. Is the goal still meaningful? Because life happens. There's so many other things that is happening. It is possible that while you're in the middle of one goal, the goal changes and you have to focus on something else. So you have to again reflect as to what is really happening. Especially suppose your intervention is going on very well, but there is a family members who has left the house and gone, or the child is upset because they had to move somewhere, or anything that happens in life. The chances are that it may interfere with the work that is happening with you here. So you will still have to kind of see and reflect as to what do I need to do at this point. You need to think about what support, what is helping the most, what new needs are appearing. As I just said, that if there's some other emotional urgency, then you will might have to probably look into that. What do I need to adjust, with the target, method, intensity? Am I being too, am I trying to, pace it too fast? Do I need to slow down, or do I need to kind of keep changing? Because a child with an attention issue also will not want to stick to one activity. They would want to kind of have a change of things. So this is something that you will have to reflect. Um, Now coming to our main stakeholders, which are the family. And family-centered care means that you are working in partnership with the families and supporting them with the child health. Now, when I'm saying supporting them, you are also supporting the parents so that they are emotionally resilient and strong to be able to support their children. So this is where the mental health and the efficacy part comes in also at the same time. So it's important when we are doing the diagnosis and everything, when we've done the assessment, when we've talked about the diagnosis to the parents, we also need to have a general idea as to the awareness and understanding of the parent, whether they've understood the child's need at all or not. We also need to understand the emotional readiness and the coping capacity of the parent, because it is a harsh and a rude shock to kind of get a diagnosis, and it's not an easy space. And we all know how the society kind of treats the entire concept of uh, neurodiversity and neurodevelopmental disorders and everything, and it actually makes the parents do feel isolated. So it's important to kind of provide emotional support at that point, to help them kind of build up their own capacity for coping and managing. You also need to assess whether they are willing for a commitment and are they available for the therapies. A lot of time you would have seen that the parents would come in and say that, oh, I need to kind of just drop in my child here because I need to go somewhere else. So you need them to completely be on board with you. Then also willingness to communicate and collaborate. You need to engage with them. You need to, the thing is, in my experience, that when we don't speak too much of a technical language, that is when we are able to actually then work on getting the parents on board with us. So create that environment so that parents feel comfortable to talk to you, set realistic goals and expectations. And when we are talking to parents about involving them, we need to create some teaching modules and training. So we need to teach them how to be responsive in parenting, how to understand their child's behavior signs and cues, understand the behavior, why it is happening, um, and then respond accordingly. We need to teach them to talk about creating daily schedules, a little bit of the behavior modification and management plans as to the antecedent behavior, like, behavior and consequence pattern, as to why a certain behavior happening and what they can do. Many times we need to talk to them about how to support their own emotions, how to identify their own triggers, and so that they are able to identify the triggers and emotions of their own child. We need to help them learn about the social skills and the teaching training. So there's a whole lot of learning that we need to kind of have for the parents also. And we need to help them learn that whatever is being taught in the center, they can use it in their own house. They can be creative. They can use the same domain, but they can do something else and work on the same activity. So that confidence, again, is something that we need to build with the parents while we are interacting with them. So, which has been a very long and the intense session. So I'll just uh, close it with saying that early intervention is definitely very, very important. It should be early, it should be intensive, active, and tailored to the family. The parents need to be involved both in the diagnosis and the intervention, and the focus should be on good screening, a comprehensive assessment, and coordinated multidisciplinary support. Multidisciplinary being a very, very important factor here. And we need systems that are accessible and organized and collaborative. So, not only from an intervention and interactive part, even from the institution side, even from the policymaker side, we need much, much more support. We need much more training opportunities. We need to actually expand the learning opportunities for the professionals as well as for the parents. And the earlier we act, the better the chance we have for supporting. So that's it. So what I'm to end, I would just say that if you want to improve the outcomes for children with neurodevelopmental difficulties, we really need systems that are accessible, organized, and collaborative. And it's important to act early so that we are able to kind of give a much better long-term outcome. So that is from my end. I'll just end with very shamelessly uh, showing the book that we had written, because this book was written basically from that perspective, because we saw a lot of difficulties, we saw a lot of roadblocks, so we felt that writing this book would help us. And for those who are interested in the NITCAP and the Fine Level 1 workshop, we are going to be organizing that in December 12th and 13th in Mumbai. So you can reach out to me if you want to. So with this, thank you so much for listening to me, and I will stop sharing the slide at the moment.
So, Neerja, first of all, thank you so much. In spite of your cold and allergies and your bad throat, you managed to talk continuously for an hour and you engaged us for an hour in such an amazing topic. I am not a child psychologist, this is not my field, but it was very fascinating to listen to everything that you had to say, and every slide was like a whole lot of knowledge put in one slide, and we just I can imagine the kind of work you're doing. So it's just unbelievable. So I'm keeping
Thank you,
the
ma'am.
I'm opening this session now for question answers. I'm sure there are folks who would like to hear more from you, and some questions that they may have. So yeah, anyone who would like to ask Neerja any questions?
Can I hold? Can I ask a question? Um,
Yes,
Hi, can you
ask
hear
the
me?
question.
Yes.
Yes,
Okay.
yes.
Yes, yes.
So basically, see, I come from a school point of view. Okay, so I work with a school, and we see a lot of children in the age group of 1.5 to 2 when they're coming to take admission, and that is when we start conversation with the parents that okay, there's something missing, but not able to pinpoint when we ask at that age to go for any kind of assessment, I think the first rude shock that the parents get is that, are you judging my child? And that is very difficult to deal with because, as a school, you also want to take this child. However, you want to also be sure that will I be able to add value to the child that I'm onboarding? There are, even though I say that I come from an inclusive school, I also know what is the school counselor to the student ratio, what is the special educator to the student ratio. So, when there are so many of the limitations, how is it in a very nice way or a polite way can I ask the parent to get an assessment done?
Um, it is a very, it's a major problem. I totally understand what you're saying. Important thing for you to do is to have these awareness programs, number one, because it is natural for the parents, because no, accepting that my child is not in tune with what is happening, others is obviously, so the first response is going to be to reject it. And teachers will usually be on the other side, like, or the counselors would be like, because you're part of the school, you're you're coming from the enemy zone. So it is going to be that way. What you can do from the school, I would say, is have at admission, or or make it a policy from the school side that at regular intervals we will be doing the screening. So if you are doing the screening, so you're not isolating a child, you are doing it for everybody. And if something comes up in that, so it will definitely increase your workload a bit, but it's a good policy to do it at the time of admission. So if you've done that at the time of admission, or you can, and if there are certain red flags in that, it's easier for you to at that time say that, okay, this is what has come out. Maybe you can get, so you are not giving the diagnosis. You are asking them to go to the pediatrician to kind of do the assessment. So you are being diplomatic. You have identified the problem. You've given them the choice to do it. Yeah. Or it can be the other way around where, you will have medical visits happening in the school, depending on how you do that. Yeah. So
So what is the
that is what.
basic feature that I can include in the admission checklist, which is basically, see, we are seeing children at the age of 2.5, who are coming for a nursery admission. So what is the basic screener that can be um,
So the
taken
so
in
the
that?
slide that so the slide that we showed, the government's RBSK thing, that's a very good screening schedule for everything. So it's just like a cross disability thing. So if there is anything, you will see the red flags in that. So you can use that, and you can say it's by the government. So it's absolutely, so you're not using anything private. You're just using something which is, endorsed by the system. It is so you clean that side from that perspective.
Okay, thank you so much.
I think we have a question from Urja Gandhi.
Yes, ma'am. Hello. Hi. It was a really very good session. Uh, Myself, Urja Gandhi, and I am from Gujarat, and I work in a DIC as a psychologist. I'm a MSc clinical psychologist. So yeah, I worked as a psychologist. I handle all kind of patient, as in cerebral palsy, autism, ADHD, intellectual. I do all kind of testing, which which you have already mentioned in the list: VSMS, autism, and learning SLD, learning disability, which right now I'm going through with one of my child. So most of I handle autism kids, and I also do a behavior planning for all of them. I also take a therapy of my kids and everything. It's a very nice working in a DIC, because already you mentioned that it's take a whole as a village to raise such kind of children. So we also have occupational therapists, we also have special educator, and speech therapist and dental. Whole DIC unit includes everything. So all the working session. So here, my question is that when we do a cerebral, when we work with a CP patient, at that time it gets very difficult to do this assessment, because you already know that CP child or have may have GDD or may not have, and later on, as we do through occupational therapy, as we do the therapy, their IQ increase a lot. Like they may go to moderate or mild. So how to assess that thing? Like how to handle that assessment?
So see, in CP, mostly what will happen is that from your side, from a psychologist side, you will be doing your developmental assessment, and that is where because it's based mostly on the motor function, so it's going to be predominantly the physiotherapist and the occupational therapist work with, and that is why I come to the functional assessment one. So even with CP, if we are doing the functional assessment, it will then give you the activities to do for the therapy. And we know this that your see, if we are doing the developmental assessment based on the VSMS and the
No, we are
DSTs,
using Denver in the starting, because it is 1 to
even,
5. So we use the Denver 2.
even if you're using the Denver 2, it is based on the ability, the activities that the child is able to do.
Yes, yes.
So that is why if you have done a functional assessment, so
Okay.
when you do the functional assessment, you understand the baseline level of the child functioning. Right. Now, after that, if you have given activities based on that, like, so there is one level which says that the child cannot pick up the cup and drink.
Yes.
Okay. So suppose if that
Assessor,
comes as
yes.
one of the lines, then what you do is that your therapeutic intervention will be that, because the
Okay.
chances are that the child is not able to do that could be because that he probably is actually not able to do it, or probably the child has not been taught to do it. Okay,
Okay. Yes.
so when you are doing the intervention, and if suppose the child is able to pick it up, then you've helped him increase his ability, isn't it? So that's why the next time when you do the developmental assessment, then the score will come higher because now you have given the training. Okay, so
Yes.
that is where the rehabilitation training will come in, because you are now identifying the baseline. So baseline doesn't necessarily mean that the child will not be able to do anything further than this. The baseline means that this is where the child is at the moment. So
Mm.
when you when you identify a plan and move up, that is where you see if the child is not able to move, then you look at that. That's when the review and reflect part comes in as to why is this not happening? Is it because of a neurological problem? Is it because of a motor problem? What is it? Will it help if we are able to provide some kind of braces to the child? How do we do that? So that is when that collaborative thought process will come in as to why is this child not able to do it. Yeah.
Okay. And also, ma'am, I would be interested in your program, which you mentioned later on. later, end of the session, where you also mentioned that you are having a program or some skill related something in a December. So I would be interested. So if you would like to share
Yes,
something
so
on.
that is mostly for professionals who are working in the neonatal intensive care unit. So you can
Okay.
come and attend it. So what I'll do is I'll share my, like Meghna has my email address. So if anybody wants to reach out to me, you can do that. So that's not an issue at all
And
from my
I
side.
also really like
Maybe
your okay, sorry.
go ahead, Urja, go ahead.
Yeah. So I really like your PPT. So if you are comfortable, if you can share with us on a group or something like that, if it's okay with you, then
I'll be happy to. No, not a problem at all.
okay.
The
Thank you
only
so
thing
much.
is some part of it is from the book, so that
Yeah,
is the
yeah.
only thing.
But it was a very helpful. A few of the
Thank you.
slides which you mentioned the overall idea of how to make the plan. That plan is really very
Yeah.
helpful. So I can show it to the center and to my colleagues
Yes.
also, so that they can also have
So,
some idea on
uh,
that.
so Urja, one more
Yes.
thing. This entire session is being recorded on YouTube.
Okay.
So please share the YouTube link with with your center colleagues. And maybe if you buy that book, then probably you'll get the whole thing, including
Yeah.
what she told in the session.
Yeah, the
It's
book.
And
much more in detail.
yes, yes.
It's much more
And
in detail in the book.
absolutely, it will be a lot more detail so that anybody who wants to start such centers or work in such centers. And Neerja, what Urja said, a few minutes ago, let's also think about creating some kind of a training for our
Yes.
therapists and teachers or counselors. I think somewhere that just knowing and enhancing that ability, knowledge, those competencies, I think
Yes.
I mean, it just came to my mind that all of us really need to learn a lot more.
Because till now, I'm working. Last 3 years, I'm working in this DIC unit at Dharampur, Gujarat Dharampur. So it's like a very. I have attended a lot of session related to occupational therapy, and related to special ed. That is again one and the same thing, because we only proceed further after the assessment. We only move forward the child to a special ed. It's something like that, because here the
Hmm.
assessment is each and every assessment I only do. Basically, developmental assessment or IQ assessment. Then only child move forward accordingly. It's
Yes.
something. So
Hmm.
it's like very helpful if we can get more informative on this. What exactly a
Mm.
psychologist's role in a DIC? Because many a time DIC unit is there, but they don't understand the role of a psychologist. Because
Yeah.
I sometimes face problem at my center related to that.
Hmm.
So just sharing my
No,
thoughts on this.
it's again, it's a give and take, like, because
Yeah.
again, because we don't understand, like, for us, it's like, we all love to live in our zone. And that is where we need to kind of step out. And sometimes it's important to actually talk about what you're doing and what you can do. So usually people assume that psychologists will just do the assessments and leave it to that, and that's
Yes.
about it. Because we many times are scared to get into the remedial intervention also. Because we don't, so the way the framework that I had actually oh, poor things. Forced my team to do was that when a child comes, it'll be after the pediatrician or the psychiatrist has done the assessment. Then they come into the EIC. The first assessment will be done by the psychologist. After that, it will go to, like, the OT, the speech, and the PT.
Yes.
While that is happening, the psychologist is going to sit with the parents and find out about the lifestyle, introduce the
Hmm.
concept of visual timetable, so that you know that the child is going to be going in for an intervention. So you introduce the visual timetable and time scheduling at that time, so that that is already started. So it'll
Hmm.
take about a couple of days for the report to come in and the whole IEIP to be made. But you're still utilizing that time to involve the parents in the entire process, so that when that activity is done in the center and the child gets used to it, the same thing can be done at home. so that there is a connectivity, so that the child does not think that I have to do this only here in the center
Mm.
and then I can do whatever I feel like at home. So it's a process. And so that is where your, as a psychologist, your skill will come in to engage the parents, get them on board, motivate them. If there are any emotional things, do that there. Because when you are helpful there, then you will be respected by the rest of the team, that this person knows how to kind of deal with the parents. So your work will definitely get in, like, too
So
much then
yes.
afterwards. But
So here in our center, we have a every Saturday there is a clinical meeting. So each one of from the department, that is, we also have optometrologist in a DIC unit for an eye. We also have Behra and Real for hearing. So there are different units. So each one of us have to present the case. So in the presentation of a case, this time it was my case presentation. So I have to make the whole history, like I have to literally what is the family work out there, because here what happens, sometimes family doesn't support, they doesn't support, only the mother is only doing whole psycho. I have to psycho educate mother is only doing taking care of a child at home also. There is no family support, because for a child to get better there should be family support. Because what happens, grandparents will give the child, we should give a child a TV or a screen time, we should give a child a chocolate, everything. So I have to psychoeducate the whole, but here the role was only till mother. So that was the one case of discussion, that why mother, how to psychoeducate, and
Mm.
parents and the family members are not ready to come in the unit and just look around that what exactly the child has gotten, but they were not ready
yeah,
only. So we
that's a
face
very
such kind
common.
of
That
feeling.
is a
Yes.
very, yeah. So that is a very, very common thing. And probably this is the time where, when you're doing the presentation, your psychological formulation is important, so that
Yes.
you're able to actually understand. And also, clinical meetings are also a good time. So it's not like a one-way thing that you have to present like a student. It is
Yes,
also a
it's
time
always
where you
one.
can actually ask the team that we need your support. We need now you to interfere, because yes, in India, medical model works. If the doctor says it, then everybody will listen. So that is the time then you will have to kind of get them on board and say that now you have to kind of have that conversation. You have to counsel the parents and the family and kind of put your foot down, because
Mm.
like till the time that happens, till the time the entire family sees that you are dealing with it as a family yourself, the entire medical
Yes,
team and the
yes.
therapist team is like, working as a family, it will obviously not function, because that's what I said, because then it will be seen as वहां जाके छोड़ के आ जाओ तब तक I'll have coffee, and that is a very,
Same.
very,
I say
and the
this
parents will
every
Yeah.
say
day.
that.
Yeah.
So that will
So
happen.
wonderful questions. These are realities, culture again, culture rooted in our culture, and those are a lot of psychoeducation is needed. So, and more so with small children, there's too much of concern. There's a lot of caregiver fatigue. There's a lot of issues that go on. So I think, very important
Thank you.
questions on
Thank you so
realities,
much.
Urja.
Thank you
Any
so
other
much.
Thank you so much.
questions? No problem. So, any other questions for Neerja? I mean, we will also share her contact. It's probably there, or in our YouTube channel also, we'll put her contact if somebody wants to get in touch with her and
It's just a
ask
quick question. Where
questions.
can I buy the book? Or where can I get the book?
Amazon. Amazon.
Amazon. Okay.
Yeah,
Okay.
let's
Yes.
put the link of the book also in the YouTube chat.
So,
And
so the
maybe I'll,
only
I'll
thing
also
that
post this on LinkedIn. Yeah, go ahead.
Thank you so much, ma'am. The only thing that I wanted to add part was that that's why early intervention is important. So what happens is that when the intervention gets delayed, when we come at a phase of the rehabilitation part, that is when the parents actually lose their stream. And
Yeah.
a lot of emotional support is needed for the parents at that time. But when we are doing the early intervention, when we are adding it, they are much more on board. So
Mm.
that's why it's important to not do it late and try to kind of identify, create more awareness programs so that we are able to actually pick it up and go for that. So
So I think,
that's what I would say.
Neerja, yeah, so one thing, Neerja, sorry, as you were talking, it just occurred to me that most of the times the parents are going to the pediatricians for checkups. And so I think the pediatricians need to kind of
Yes,
refer the parents to the
yes,
psychologist or the OT, or so it's very important for all the pediatricians to really know this, and the schools,
yes,
because if a child is
yes,
going to a
definitely.
preschool, then the teacher is
Yes,
somebody who will be observing. So I think the psychoeducating the doctors and the teachers probably may help,
yes,
because who is that
yes,
first person who's going to tell the parents that your child needs this?
yes,
Sometimes some schools don't have counselors. They generally have to have, but they may not have. And then there are children who go to play schools, not schools.
yes.
They're going to these babysitting centers and daycare centers. So what about those people? I mean, it's like, it's
So
just
we do that.
expensive in the
So
early.
in our setup, like in our the defense setup, we do that regularly. The creating
Hmm,
awareness, going to like the creche, like getting
hmm,
the
hmm.
teachers trained, like there's always this kind of a training which is happening so that people are aware of it. So there are a lot of community conversations and talks to the parents, talks to the teaching faculties, everything. So
Hmm.
it's done on a regular basis because ultimately we have to remember that public memory is short. So every 6 months we have to keep doing
You have to
this.
keep doing
And
it.
I remember
Wonderful.
very early in my career when I used to do these community talks, I used to get very frustrated, and I had told one of the person who was there, like, what's the point in doing it? Like, like we are just talking and I don't even know whether anybody is getting anything. And they said that even if 1% of people
Yeah,
understand what you're talking about, it's worth it.
yeah,
So we're like, that's a good point, like actually, because our job is to keep creating the awareness
abs-
and keep talking about what we are doing and explaining the scope of it because everybody is scared. Because even if we do the assessments, what after that? So what
yeah,
are you doing after that? So that is why this concept of the early intervention, this whole thing, it's important for us to see it from end to end, to see what we are doing, how we are doing it, and what is more meaningful for the families. So,
absolutely.
so that was a thank you so much, ma'am, for giving me the
Thank
space.
you so
I can go
much.
talking about this for hours.
Absolutely. It's something your passion, and I think this was amazing. So, if there's no other question, then we can close this session. So, anyone else who wants to ask any question? So thank you so much, Neerja. From the
Mm.
bottom of my heart, this was like when you talked about what you do and the book. I mean, immediately it came to my mind that let's organize a session where we just invite professionals, and it can be such a wonderful learning opportunity. There's a lot more to learn, and maybe we'll connect with you one on one to figure something out,
Definitely.
because I can see that there's a need for our professionals to also be trained in some of these concepts itself.
Yes,
So, thank you everyone
definitely.
for being here. Meghna, thank you so much for coordinating. And I have to thank my team, Akansha, my interns, everybody who made this happen. And thank you everyone for attending today's class, today's session. So, have a lovely rest of your Sunday. Thank you so
Thank
much.
you. Thank you so much, ma'am.
Thank you. Thank you, ma'am.